Welcome to TraumaCast. It's like a podcast, but about trauma. Listen and learn from our team about current trends, new research, and continuing performance improvement efforts. This education is eligible for CNEs. Successful completion includes watching or listening to the entire session and completion of the attestation and evaluation. The link for the evaluation and attestation is located at the end of this video. We hope you enjoy. Please let us know what you think. Well, welcome everyone to our very first episode of TraumaCast. Our Burncasts have been so popular that we decided that we were going to piggyback off of it and start TraumaCast. Now, you will recognize Liz Weibel because she is a staple on our Burncast, but today we have Jen Fritzing, and she is the trauma program manager. Before we get into like any type of questions or answers or anything about it, I'd really like to take this time to explain a little bit about what all three of us do with trauma. So we'll start with Jen, then we'll go with Liz, I'll finish it off, and then we'll go into some discussion. So Jen, tell us what being a trauma program manager is.
Hi, I'm Jen Fritzing. I'm the trauma and burn program manager. And so I basically look at all aspects of trauma and burn care, from that of the clinical care that our patients receive and looking at quality improvement metrics, care guidelines, what the latest and greatest is in research, and making sure that we are incorporating evidence-based practice. I also am responsible help oversee the research arm of trauma, again, working with Dr. Bird on the internal research that's being done with trauma and burn patients. And then finally, I oversee the registry. All trauma care there's about 250 data points that get entered into a national trauma database registry that allows us to compare ourselves with other hospitals, with other trauma centers. Lets us do some benchmarking. It also helps us be able to identify and pull data just within our own trauma center. And then I think finally, Cindy, I work with you as far as overseeing some of the injury prevention, which Cindy does the bulk of the work. I just make sure the funds are available and continuing education.
I did it. I started talking and I was muted.
I saw that.
Before we move on to Liz, Jen, can you explain a little bit more about what it means to be a trauma center, like a level 1 trauma center?
Sure. Level 1 trauma center means that we comply with resources and metrics to the ACS standards. And for us, we also comply with the MIMS, State of Maryland COMAR. And so to be a level 1, it's to be recognized as a trauma center in which we have the right people trained in the right places with the right equipment to be able to take care of the trauma patient, the right guidelines. We have research in place, and we are pretty much have a whole team of people that are dedicated to know and understand how to take care of that trauma patient. To be recognized as a trauma center, we have both the state of Maryland and the American College of Surgeons come in every 3 years and evaluate every aspect of our program to assure that we continue to improve and we continue to uphold the standards of care for optimization of care of the trauma patient.
Okay. And Liz, tell us a little bit about you and what you do with trauma and burn.
Absolutely. So some of you may recognize me. I have been with the service for 13 years. It's a lot. I usually
that
just
is a lot.
That's
a
more than a decade, but 13 years ago, I started as an NP on the trauma service. And for the last 4 years have been working as the PI coordinator. So what does that mean? We're responsible in our office also for the scrutiny of the care that we give to make sure that every single patient who comes through the ER doors has a thorough chart review by myself. Jen does a bulk of it with the trauma patients as well. So if we start to see trends, we pick up on those. We meet weekly with our trauma team, our trauma leadership team. We review cases. where things went really well, or maybe things have opportunities for improvement. And then as a team, we decide how to approach that. Is it a new guideline we need written? Is there a system change that needs to take place? Is it some level of education? So there's a lot of patient review, also a lot of program development too. Right before COVID, we were kind of putting everything in place for telehealth, and it really shot off. So we're constantly looking for better ways to improve the quality of the care and access to care for our patients.
You put that very well.
Thanks.
Sometimes
Cindy,
it's hard
what
to
do you
explain
do?
what you do. I know. I was like, oh, geez,
know,
I have to
right?
explain what I do. I'm the injury prevention, education, and outreach coordinator. And it's kind of fun because I'm never doing the same thing every day. As Jen mentioned before, injury prevention is not only is one of my jobs, but it's one of my passions. And, we always want to keep kids safe, but I'm always trying to find like new and innovative ways to get the message out there of how to keep kids safe. And if I ever see you riding a bike or a scooter or anything that's on wheels that isn't a car without a helmet, I'm going to come after you. It doesn't matter how old you are. You can ask anybody in this office. For education, so since we are a level 1 trauma center, and Jen was explaining that earlier, that means that we have to hold any nurse that's taking care of a trauma or a burn patient to a higher standard of education. And that means those trauma and burn hours. And I guarantee that 95% of the people watching this is because they need trauma hours. But so that's part of my job, is to make sure that we have like fun and interactive and like lots of different ways to get those trauma and burn hours. And then for outreach, any patient that's transferred here, I always do follow up with the outside facility. So that's Cindy in a nutshell. So now that you guys know all of us, our very first topic that we're going to discuss here on TraumaCast is about labs in the emergency department. And I would like to start out by asking Jen, what is the difference between basic trauma labs and comprehensive trauma labs? I feel like any kid that is in the code room as a trauma, we always hear, oh, order basic labs or order comprehensive labs. And, what exactly is involved in those labs, and why would you get one versus the other, and what's in them?
The simple answer to that is I look at basic labs as screening labs. And so you only do screening labs if you have a patient who comes in who's relatively stable or who has minor injuries. In those basic labs, you're going to get a hemoglobin, you'll get an ALT, AST, and a UA. I don't think I'm missing anything. The hemoglobin is a screen, so we know, are they bleeding? It'll give us that indication, because the child may be bleeding slowly enough that we don't see any outward signs and symptoms. And so we can look at that just from the screening perspective.
Okay, before you go
Mhm.
any further, tell us why we don't need a hematocrit. Tell everybody the secret. This is the
So-
best, like so great.
The secret is if you know your hemoglobin, you automatically know your hematocrit. So if you take your hemoglobin, times it by 3, that's your hematocrit level. So if you have a hemoglobin, you always know what your hematocrit is. If you have a hematocrit, divide it by 3, and there's your hemoglobin. And I learned that, and every time I see a CBC, I look at it, I do the math, and darn it if it doesn't work every time.
Same. I do it too. Liz, do you do that? I mean, every time I'm like, I either divide by 3 or multiply by 3, and I'm like, it works.
I have honestly tell you, I've never done that. I have
Oh,
never
it's
done
so
that, but
brilliant.
I will.
Yeah, it's so brilliant.
So
Okay,
the
didn't mean to
beauty of
interrupt
it
you,
is,
Jen. I just love
That's
it.
okay. You don't need an H and H. You just need an H.
Right.
Right.
And it doesn't matter which age.
Yeah. All right. So we also get an ALT and AST, and that's screening for abdominal injury. If you have, if your liver's lacerated, your ALT, AST is going to go up. We will, on kids that are asymptomatic with a belly injury. So patient comes in, they don't have any pain, they have no bruising, they have no clinical signs of abdominal injury. The ALT, AST is our screen to see, are we missing something? And so if that ALT, AST is elevated, then we'll know to get a CT. If it's not elevated, great. We just saved that patient radiation. And then the other screening lab we're going to get is a UA. The UA is particularly important, mainly for the red blood cell count within the UA. What we're looking for from a trauma perspective is there any renal type injury? And we will see that with microscopic blood in the urine. Now everybody can have a little bit of blood in the urine. You know, if you have, what is it, 1 to 15 RBCs in your urine, that's something we're not too worried about. But once you get more than 15 RBCs in that urine, we'll probably go ahead and repeat it just to make sure nothing's crazy, and see what it comes back as. If it still comes back elevated, again, now we have a reason that we may need to do some imaging. So a lot of these screenings of the basic labs that we do are to figure out, do we need to image the patient or not image? And I don't know if people are aware, there are studies out there that really look at radiation exposure to children, and not so much your x-ray, not a whole lot of radiation with x-ray, but with CT scans, there's a whole lot more radiation. And the research out there shows that kids that are exposed to radiation as a young child are more prone to get an adult with cancer. And so that's why we are so incredibly careful about what patients we want to do imaging. And it's why the basic lab panel is going to be so important. Now oh, go ahead.
So, you know what, I think I'll ask my basic lab panel questions after you explain comprehensive
Okay.
and why we would get a comprehensive. And Liz, I got questions for you too. Don't worry.
Okay.
The comprehensive panel, I look at the comprehensive panel as, I know I have a kid with injuries. This is a child who comes in, they're obviously bleeding. They obviously have something wrong with them, whether it's a fractured femur, an abdominal injury, a broken pelvis, a head injury. I'm going to get the comprehensive panel because the comprehensive panel has a full CBC. So I can not only get my H and the other H, but I'll get a white count and all the fun stuff that goes with that, a platelet count. I'll get coags, and I'm going to put a pin in coags here for a minute and go back to it. I'll get a full CMP, which will have not only your screening labs of your ALT, your AST, but it'll have, you know, your sodium, your potassium. All that comes into play when we're looking at our trauma patients from a cellular level. We'll also get a type and cross, or type and screen, I guess. Now, the importance, I'm going to circle back to the coags. This is going to be really important in any child that may have to go to the OR within the next few hours. Where we've gotten into some trouble is coags were delayed. We weren't able to get enough blood. Maybe just the CBC was sent, or the CBC and the CMP, and we didn't have enough blood for coags. The patient ends up in the operating room, and the surgeons don't want to start operating because they don't know if we have any issues with coagulopathy. And so these are the importance of every element of the comprehensive panel. Now, there's one other addition to the comprehensive panel that it's a little bit tough, and it's a newer element, and that's the TEG. For every trauma stat attending, a TEG should be added into the comprehensive lab panel. And it's much harder than just putting an order and putting blood into a tube. When we do a TEG panel, the NAL not only orders it, but she has to call up to the lab so they can do the quality assurance before the lab specimen gets there. When the nurse draws the lab, it needs to be put in a blue top and rotated, inverted several times, and then immediately walked up to the lab. So this is not a lab that can sit on the counter in the code room or on the NAL desk out in the hallway for any length of time. It truly has to move. And TEG is going to help us look at the bleeding capability, basically the strength and duration of their clotting factor, specifically the platelet. So may not help us in the moment, but will help us long-term be able to target management of the patient's blood products that we need.
Okay. So Liz, now that we know the difference between like basic and comprehensive, what is the one thing that you've seen in the PI process that we struggle with the most?
It is the UA. It's the UA because we don't catheterize for a UA. And why not? It would be really easy just to kind of throw in a catheter in the trauma bay, and then you would have all of your labs right then and there. But if you think about it, it's going to cause some potential trauma, and then you'll have a falsely elevated microscopic red blood cell count in the urine. So we only bag or let the child void on their own for the urinalysis. And so most kids we're not putting on the bedpan, you know, in the middle of the code room. We're waiting for them to have a chance to void, again, either in the diaper with a urinary bag on, or go to the bathroom. So a lot can happen between leaving the trauma bay, going to an ED room if they're admitted, possibly they're upstairs in the ICU or on the floor. So you can ask Jen too. I think the UA is probably the #1 thing that we have a problem getting, just because that order doesn't transfer over to the floor. So if you're a nurse caring for a trauma patient in the ICU on surgical care, make sure that that urine didn't fall off. Make sure that it's resulted or there's a duplicate order in there, because it's really essential for our screening process.
So, and Jen or Liz, either one of you can answer this. So if a patient goes to the trauma bay and they order basic labs, a UA is included in that. And again, we're not looking to see if they have a UTI. We're looking to see if they have blood in their urine,
Yes.
right? Okay,
Yes.
so we're trauma. UTIs really aren't in our scope there. We're more worried about blood. So if we have a kiddo and basic trauma labs are ordered, are kids discharged home from the ER without having that UA result?
They shouldn't be.
Mhm.
Okay.
All our basic labs, including that UA, should be resulted before patients are discharged.
How long does it take for a UA to result?
Well, I mean, you could always dip it too if you needed to. We're just looking
So,
for. No.
Okay, so that's what I was trying to
Okay.
get at. So because so we need to know, like, how long does it take, and does it have to be a UA that goes to the lab, or can it be a dip?
No, so a dip is only going to tell you yes or no to blood. It's not going to tell you how many red blood cells you have in there. And so it's something I actually talked to Dr. Bird about, just to make sure that there wasn't something I was missing with that dip versus UA. And he did agree that, I mean, if we get something that just says, yes, you have microscopic blood, maybe it's only on the UA, it'd only be 10. And so we don't want to consider that a positive screen with just a yes. We truly want to know what it is. And so our team knows exactly what we need to do. Do we need to repeat it and see if there's still blood in the urine, or if there's anomaly, or do we feel like we are in the clear because it comes back early? So where a urine dip results much faster than if you send something to lab, it doesn't necessarily give us the information that we need.
So if somebody did a dip and it said no, but they were still waiting on the UA, then what?
Good question. I guess I've not really thought about the fact that a no could mean that they were safe and they could go.
Yeah,
I probably need to look at what the false negative and false positive attributes of a dip is, and it's not something I've looked at, to be honest with you.
yeah, because I'm trying to think of, like, we know that the ER,
Mhm.
everybody's ER, not just us, but everybody who is in an ER, it's really busy. And the dip doesn't give us an exact number, which is what we would need. But if a nurse if that's what everybody was waiting on, and the kid peed enough that they did a dip and they sent a UA, if it was negative, would that be enough?
Yeah, I'd have to look at the sensitivity of a urine dip to see what the false negatives and false positives are.
All right, well, stay tuned,
Yeah,
because we'll
stay
answer
tuned.
it on
Yeah.
TraumaCast number
Yeah.
2.
Yeah.
Yeah, we'll find out. And that might be a good way around it for kids that are waiting on that sample. But generally speaking, how long does a UA take to run and come back? Like, because everything from the ER is like put in as stat, right? So a stat is what, an hour turnaround?
Yeah, technically it should take an hour. I would dare to guess that it probably takes a little bit longer than an hour.
Okay. So, Liz, if
Yes.
a kiddo is in the trauma bay and then hangs out in the ER for a while, and then is transferred to surgical care or the PICU, so we know that one nurse should tell the other nurse, like, hey, we ordered a UA, but this 3-year-old, they're not peeing. They don't like us. They're mad. We had put them in a C-collar. They
Mhm.
didn't want their IV and they are refusing to pee. And they can't get it. And so what does the bedside nurse in surgical care or the PICU do if it's not in report whether they got a UA or not, or if the kid can't pee, or like, what should they do?
You're saying, how do they identify that it's still missing?
Yes, or if it needs to be reordered, like where did they look? What do they do? So, because we got to put, like, we hope that it's in report. And if it's not in report, we hope that the receiving nurse will ask the question about the UA, because every trauma patient that's admitted should have basic trauma labs, right? That's an overall scoping. So no matter what, if a patient is admitted to the hospital, they have to have a UA. So what if the nurse doesn't say it? Like, what does the receiving nurse do?
Well, at first, I mean, I think most importantly, I would go back to the source and just see if you can get that information from the nurse. If the nurse is left for the day or they can't contact him, I would probably, see where it is. I'd probably pull up the orders in the ED and see if there's any chance of, anything being discovered that way. You could call the lab as well and see if it's there. Most likely, you're probably going to need to ask the provider to reorder it, though.
One of the problems we've seen is when the UA is ordered in the emergency department and the patient transfers to the floor of the ICU before it's been done, the floor nurses, when they look for results, it says in progress, even though it's not been collected. And so just by looking at the chart itself, they're going to get this false sense of security that a UA is cooking, where it's not. And so I kind of agree with Liz. I would call back if the ED nurse who gave the reports available, talk to them. Heck, even mom and dad might be able to give you an idea if it's been drawn. Call the lab, and I'm kind of with Liz also. You probably at about a 90% chance if it says in progress that it has not been done and we need to get a new order put in.
So what if the patient arrives with a cup of urine with no label and they can't find the order in the system? Because what I've seen happen is, when we order labs in the code room, the reason why it says in progress is because we automatically print those labels. So and this is like, technology, we can love it or hate it. It can help us or hurt us. So in the code room, we say that everything is been collected, which means that it's in process, because we print all the labels at the time of ordering. So it looks like the kid is already peed. It looks like we've already gotten blood. 99% of the time we get the blood, we put the labels on the blood, we send it. But the other time we just get the empty cup, and the empty cup follows the patient through the ER. So what do we do if the patient comes up with a cup of urine and no label, but it says it's in progress? Then what? What does the nurse do? What does the bedside nurse do? Do they just ask the resident to put in another order and say, can't find this label? Is there a way to reprint a label? Like, what do we do? Like, what does a nurse do?
I think you'd have to reorder it, right?
Yeah.
Yeah.
And I wouldn't do
get another
anything with an
label.
unlabeled specimen.
Right. Exactly. Yeah.
Maybe that's
'cause
what
you don't know
trying
if
to get at. I would throw that thing out. Yeah, you don't know.
just get more pee. Like
Absolutely.
if there's not a name on the pee,
Right.
just get
Yeah.
new pee.
Well, again, yeah.
Our trauma patients are going to pee. Just give them a
Yes.
minute.
Yeah. And importantly, what are we looking for? We're looking for kidney injury. We're looking for maybe an occult pelvic fracture. Like, this is not nothing. There's a reason we care about it. So
I can throw something in. There is a handful of times where maybe we don't get the urine, and there's one example of when that's okay if we don't get a urine. If we have a patient, yeah, it is. I know, crazy thought. If I have a patient who's had an abdominal CT and we still don't have a urine, I'm usually okay with it, because now we've done the gold standard. Once you've done the CT, I don't need the screen. Does that make sense?
Mhm.
So if we've not gotten the UA and we never get the UA, like when we look at our data, I exclude those patients from counting against us, because I already know the answer to the question because I have the CT to look at.
But we should never get a CT in lieu of a UA.
Right. It's just
Right.
sometimes they're getting a CT for another reason. Their
Yeah.
ALT, AST was high. They have abdominal symptoms, clinical
Or
symptoms.
suspected pelvic fracture. They're gonna,
Exactly.
right.
CT
Exactly.
from another hospital and they were transferred in.
Yes.
Yeah.
And here's the deal, the UA is ordered, and yes, it's a great idea to get it. It's non-invasive, it doesn't hurt anything. But remember, it's a screen.
Okay. Okay, so we are almost at our half hour mark. Poor Jen. She was worried we weren't going to have anything to talk about for a half an hour. I was like, we could still talk for another hour and a half about this stuff. But I'm going to ask, I'm going to end this the same way we end the burn cast. And I'm going to ask Liz and you, Jen, to name the one thing you want the ER nurse to remember about labs in the ER and the bedside nurse to remember about labs in the ER. Liz, you get to go first. So
Okay,
two things.
yeah, again, again, just communication, have that communication. If your analysis is not complete and it still needs to be done, there's no other imaging present, just pass that on and report that, there's a reason that we've pared it down to 4 labs, but these are quite necessary. And I guess alternatively too, if the ALT, AST are elevated, just anticipate that child is going to need an abdominal CT with IV contrast.
Okay. And then for the bedside nurse that isn't in the ER, anything that you want to talk to them about remembering about labs in the ER and what to look at? And
can I tell you one other thing? For non-accidental trauma, our threshold's lower. So it's actually 80. That's our cutoff. So because we're looking for older injury, not necessarily acute injury. So
when you say 80 for what labs?
For both ALT, AST, I believe.
And what's the normal numbers if it's not a suspected NAT?
Oh, it's going to be in the, it's going to be much less than 80. 10, what, right, Jen? 10.
Yeah, it's in the 10s and 20s.
10, 20. Yeah.
Okay, so that's a normal.
Normal, yeah.
But what's the high bracket for patients that the suspected NAT? So if it's just like a kid that was in an MVC, we're not worried about non-accidental trauma. What does the ALT and the AST have to be to make us go, we need to do a abdominal CT? What are those numbers?
150, 200.
Okay.
Correct. Yes. Consult the trauma manual, but
yeah,
150, 200. But honestly, if there's a bruise to the liver, it's going to be, 300, 400. If it's an acute, liver laceration, it's going to be way, way up. We're not going to be, worried about something that's, 30 or 40. It's going to be quite bummed.
But the threshold for imaging is lower if NAT is suspected.
You got it. Yes.
And that number is 80 for either one of them, not
Correct.
one or it doesn't have to be both. It just has to be one.
Yes.
Okay. And Jen, what are your thoughts? Number one for the ER.
So for the ER, I would say if you're drawing labs on a trauma patient and you get a limited amount of blood, instead of assuming what the priority labs are, is make sure you talk to the medical leadership in the room of what priority labs are going to be, because different situations are going to give different priority. And so I think everybody's sharing that. I think for everybody taking care of trauma patients, the trauma app is available for your phone. And right now I'm looking at the trauma app, and if you go under radiology and it says CR imaging, so code room imaging, and right here I see in black and white, if there are no clinical symptoms, but AST is greater than 200 and ALT is greater than 125, or if it's NAT patients greater than 80, then we should do abdominal imaging. And so we do have a resource that can be at your fingertips to be able to answer some of these questions. If you go to the lab section, it will talk to you about the difference between basic and comprehensive labs and why we do each one. So pretty much everything we've talked about, or a good amount of what we talked about today, can be at their fingertips. And then the last thing I would say just for the flora in the ICU is look at that UA. If you see it in progress, do some more investigating to see if we still really need it.
Because in progress means the label was printed.
Yes.
It doesn't mean anything else.
Yes.
And then I normally don't add anything, but I'm going to add one thing at the end of this. If you are taking care of a suspected NAT kid and they have ordered labs, especially additional labs that they are ruling out things, please try and make sure that you get all of these labs before they get a transfusion. So if a child needs blood, get all your labs before we send the blood. I know it sounds kind of counterintuitive to like bloodlet a child before you give them blood, but this is the one case where it can be really important. All right. And thank you guys so much for joining us. And we can't wait to talk to you next time, where we will have the answer to, does a UDIP work for a negative result? Thanks a lot.